So the next is Glen Nielsen, who is a senior lecturer in neurological physiotherapy at St George's, and I think most people here would either know of him or have heard of him. He's done a big study in physiotherapy for FMD. I'd be interested to hear what you say. Thanks very much.
Great. Thanks so much for having me here today. I'm going to just crack on straight away. My plan is just to talk briefly about our randomized controlled trial of physiotherapy, and then I'm going to give you what I think are 6 good reasons why you should have a specialist physiotherapist in your FND team, talk about some limitations and try and illustrate it with a case example. I also want to acknowledge that I don't think there's time for an OT presentation. There's a lot of crossover between OT and physiotherapy, so much of what I say might be relevant to OT, and they also have their own unique role, like the very, very important role of vocational rehabilitation. So our randomized controlled trial, we had 11 sites in England and Scotland, and we recruited 355 patients who were diagnosed with FND. They had motor symptoms of FND. They were diagnosed by a neurologist. Half were referred to treatment as usual physiotherapy, which was usually a referral to their community neuro team, and the other half had our specialist FND physiotherapy treatment, which was 9 sessions. It followed a workbook, and the physiotherapists who delivered the specialist physiotherapy all completed a 1-week full-time training course. We followed everybody up at 12 months. This happened either side of the COVID-19 pandemic. So there were 89 patients who were unable to receive their randomized intervention because of lockdown and cancellation of face-to-face services. So they were excluded from the trial, and we had 90% retention at 12 months. So this is what we found. Our primary outcome measure was the SF-36 physical functioning, and you can see that both treatment groups improved in the trajectory there, and there was no difference at 12 months between the 2 physiotherapy treatments, even after adjusting for baseline differences. But some of our secondary outcome measures were significant and in favour of the specialist physiotherapy approach, including the CGI. This is the patient's perception of change to their motor symptoms, and this is the recommended outcome measure for F&D trials, which I think Tim Nicholson will be talking about outcome measures a bit later on. So we found more people in specialist physiotherapy rated their motor symptoms improved, and this was statistically significant. So those in specialist physiotherapy were twice as likely to report improvement in their motor symptoms at 12 months. Over the trial, there were no serious adverse events that were deemed to be related to receiving physiotherapy. And also satisfaction levels were very high. So, and that was for both treatment groups. But in the specialist physiotherapy group, 89% of participants endorsed being extremely likely to recommend their treatment approach to others. So against this sort of rather confusing evidence and data to interpret, I think we can say that, firstly, patients want physiotherapy. They engage well with that treatment. In similar contexts, I think it's a safe treatment. And I think it's useful for at least a proportion of people. So here are 6 other reasons why I think you need a specialist physiotherapist in your team. Firstly, of course, people with FND have motor symptoms. So there's the core motor symptoms of FND, things like weakness, tremor, and gait disorder. But patients, most of the patients I see anyway, have other physical symptoms or conditions. And these are commonly predisposing, precipitating, or perpetuating factors for their FND. So here, the common one that I see that's relevant to physiotherapy is chronic pain. And so these coexisting physical symptoms need to be considered as part of treatment. And of course, pain syndromes overlap with FND, and here there's a clear role for physiotherapy. And another physical coexisting symptom that I see in a proportion of my patients are hypermobility spectrum disorders. This doesn't affect everybody, but when we see it as physiotherapists, we feel that it really needs to be addressed. And particularly it needs to be addressed for patients to stay well, to maintain their changes in movement. So the second reason why you should have a specialist physiotherapist is that chronic symptoms result in secondary problems. So a proportion of people with FND, even after treatment, will require a wheelchair or a walking aid to be able to access their environment. And that comes at a cost. So you might see disuse weakness, but you'll also see joint pain and other problems. And those problems are amenable to physiotherapy, even if the functional motor symptoms might not have been. Although it's relatively rare, fixed joint contractures is sometimes a complication of fixed dystonia. Once you get soft tissue shortening like this, conservative treatments generally don't have much of an impact. And also these patients usually aren't considered candidates for surgery because of high complication rates. So we really need earlier and better physiotherapy, at least to try and prevent things from getting to this stage. And also a consequence of chronic disability is the accumulation of lifestyle illnesses, things like cardiovascular disease, diabetes, and this has an impact. For example, this study which found a higher than expected rate of mortality. And so I think we have a really unmet potential, or maybe an obligation, to help people live well with disability. So this might be with exercise, but also other ways to help people live well. The third reason why I think you should have a specialist physiotherapy in your team is because physical interventions can have psychological benefits. Our colleagues in chronic pain are really leading the way with this type of approach, which they call psychologically informed physiotherapy. So they mean something quite specific by that. We're not doing psychological therapy. We're still trying to address movement problems. That's our sort of goal, and our interventions are aimed at movement problems. But the interventions are informed by an understanding of things like anxiety, depression, interpersonal difficulties, and things like avoidance behaviors. So maybe one example that probably I think about a lot is somebody who might seem to have a bit of a panic reaction while they're doing their standing practice and they start to wobble. And so I might think about trying to get them to stand with that feeling, to habituate to it, and then maybe they can start to use more appropriate balance reactions. This study, I think, is really interesting, the idea that sometimes both physical and psychological interventions can work by the same mechanism. So this mediation analysis of the PACE trial found that both CBT and the physical intervention, change in those interventions were mediated by a change in avoidance behavior. And of course, we know that physical activity and exercise can have positive impacts on things like anxiety and depression, which are relevant to people with FND and chronic disability. Another very important reason is that the contemporary mechanistic models for FND really underpin our physical therapy approaches. So the mechanisms that I think are most relevant to physiotherapy are attention, an excessive amount of attention directed internally, and also expectation. So with attention, patients over-attend to their sensory things, and they over-attend to the movement. They try and move. They try and control their movement. And this causes problems. This is an example. If you've seen me talk before, you've seen this. She has a functional gait disorder. She's trying to walk. She's trying not to fall over. So she's attending. But watch these steps at the end. Those ones just there and there. They're a bit more normal, aren't they? It's because she gets to the end, she's relieved, she stops trying, and she moves automatically, released from that self-focused attention. So we can look at that together, this person and I, and we can say, let's have a look to see if we can find some more of that automatic movement in therapy. So there might have been a lot of work up towards this, so we're getting that automatic movement. We'll shape normal walking perhaps on a treadmill until we get good, better quality walking. So redirecting attention to get that automatic movement can make a big difference for some patients, but it's part of all of my treatment. The other mechanism we talk about a lot is expectation. So this is that idea of strongly held expectations in predictive processing models of FND, impact motor output at that pre-conscious level. So maybe we can specifically target these unwanted expectations in physiotherapy. All our physiotherapy treatments, all of them start with education, and we explain FND based on a symptom model that's biased towards more physical aspects, so expectation and attention. So maybe through education we can start to introduce the idea that things can change. And then through our movement retraining, we're constantly demonstrating to the person that sometimes they can move normally. We do that with mirror feedback and video feedback, and so they might start to change their expectations through, I guess, a process of experiential learning. And this sort of mechanism-targeted approach to physiotherapy is described in our consensus recommendations paper. My fifth reason why you need a specialist physiotherapist is that I think skilled physiotherapy can minimize iatrogenic harm, and it's well documented that people with FND are at risk of iatrogenic harm, and I see it all the time in the people I see. So maybe physiotherapists might help in this way by helping people understand their diagnosis if they get early access to that patient. By helping them understand the diagnosis, they might engage them in an appropriate treatment that's meaningful for that person, so a treatment that they're looking for. So they might not be out looking for other people who will help them if the core NHS won't, and then sometimes they get treatment from unhelpful interventions, they might get unscientific treatments, or they might have treatments such as surgeries that go on to make things worse. So I think timely physiotherapy can help minimize iatrogenic harm. But I think it also needs to be informed physiotherapy, because the physiotherapy approach for FND differs the way we do some of our other neuro rehab. For example, in spasticity, serial casting is a very appropriate intervention, but in functional fixed dystonia, it's not. And in this particular case study, casting was documented to at least start or worsen fixed dystonia in a proportion of people. And the case that I showed you before, that certainly was the case there, where her fixed dystonia started from being serial casted after a dislocation for too long. So we need informed and specialist physio. And finally, physiotherapy, I think, can help save money for the NHS. So we know that there are high health and social care costs. Our previous feasibility study showed a very favourable cost per QALY gained with treatment. So it was in the threshold of cost effectiveness reported by NICE. The health economic analysis for the randomised controlled trial has been sitting with the journal for a very long time. I expect it to be released in the next week or two. The results are under embargo, but maybe they're similarly favourable. We'll wait and see. But there are limitations with physiotherapy, obviously, and some of those limitations relate to the system. So a lot of community physiotherapy services around the UK will not accept a referral for people with FND. There's lots of different reasons for that. And one reason is that when you speak to these services, they're genuinely afraid that if they open up to one referral, their already stretched services will be flooded with referrals from your most complicated patients that they feel unable to help, and it will send them to breaking point. So I think we need to do more PR and outreach support if we're expecting community teams to help. Sometimes there's a lot of inexperience in community teams. Of course, there are plenty of community teams that do really fantastic work with FND. Some teams are really limited to the number of sessions they'll provide, 1 or 2 sessions, which they may as well sometimes not do any in that case. And also in community teams, there's no great opportunities for joint working and multidisciplinary working. And we know that's really, really important. It's so important. Our specialist services, we have a couple around the UK, are also full of limitations. We know that waiting times are so long that sometimes those services just aren't useful for our patients. And they can see very few patients, so not many of our patients get access to it. And also they have very strict selection criteria, don't they? So, and this is probably for very good reason, but people with the most complicated comorbid symptoms are often excluded from those services. The reasoning is because sometimes those services make matters worse, and I've seen that happen. But the consequence of that is often the most complicated patients are treated in the community by our least experienced clinicians and therapists. So we probably need to think about how we can do more outreach support. In terms of physiotherapy itself, it's really tricky to do physiotherapy for somebody who has intermittent symptoms. So when they turn up and there's no observable symptoms, physiotherapy probably isn't the right place to start for that person, or it may not be appropriate at all. Patients who have very severe pain and fatigue, and that's dominant in the picture, that needs to be treated up front. That needs to be considered really first or in parallel with their other symptoms, and they need a much slower stream treatment. Coming in all the way to central London from somewhere far away isn't going to help that person. They need to have some level of agreement with the diagnosis. They need to be psychologically well enough to engage with physiotherapy and to maintain the benefits from physiotherapy. And also we need to think about social factors, and those are really, really important to think about if it's the right time to start rehabilitation. So if there are ongoing conflicts and those conflicts are making symptoms worse, you'll be doing sometimes that person a favour to say, let's just hold off and wait until you've got room in your life to engage with physiotherapy, to when you've got some childcare, to when you're in a better place, to really focus on yourself. We looked at which baseline factors predicted outcome in the specialist physiotherapy intervention of our trial. And we were really surprised, actually, that there were no convincing predictors of outcome from physiotherapy treatment, from specialist physiotherapy treatment. So things like symptom duration, pain, fatigue, depression, anxiety did not predict outcome or sort of impair somebody from getting at least some benefit from rehabilitation. So those things themselves shouldn't be considered exclusionary, but it may change how you deliver it and in what context and what mix of skills in your team that person needs. So I'm going to try and illustrate that in a case study about how things went initially a little bit wrong and how they were pulled back because they got the right diagnosis by somebody who understood FND. So this is Ed. Ed's a 29-year-old security manager. He lives with his partner and 2 children. He's got a lot of hobbies and interests, including heavy metal drumming and superbikes. And he had some past medical psychiatric history, which he sort of described to us as something in the past that he'd resolved. 3 years before seeing us, he was involved in a motorcycle accident. So he was hit by a car, and he flipped up, somersaulted over the car, and landed flat on his back. He had a liver laceration. There was a lot of blood loss at the scene, and it turned out he had a spinal fracture. And he described to us tellingly, I was conscious throughout the whole ordeal. So he was rushed to hospital, and the MRI mercifully found that he didn't have a spinal cord lesion. So once he was stable, he was sent home to wait for an admission to a spinal rehab unit. And it was while he was at home waiting for rehabilitation that he developed functional seizures. He eventually got that spinal injury admission, and I don't think they were necessarily experienced or had the right skill mix to adapt their spinal cord injury rehabilitation for somebody who had neurological symptoms but no lesion on their spinal cord. So he was set up for wheelchair living and discharged after 2 weeks. And then 3 years after his initial injury, he turned up at our F&D neurology clinic, where he was diagnosed with FND. And his primary symptoms at the time were pain. He had seizures. He was completely unable to move his lower limbs, and he had no sensation at all coming from his right leg. So we knew he needed psychology, and that was probably one of the first things that he needed. And we referred him to psychology, but there was going to be a 9-month wait for psychology. So we brought him in and thought, what can we do in physiotherapy in the meantime? So this is Ed doing a transfer from the plinth to his wheelchair. You can see he's using his arms to reposition his legs. If you're a bit eagle-eyed here, you might see some automatic movement of his leg. But essentially, that's how he got around. So what we want to do in physiotherapy is get him weight-bearing on his feet as soon as possible. So what we often do is we get people on a tilt table. Often in neuro rehab, you'd use an electric standing frame, but in F&D, they're very good at just sitting on the standing frame, and so they're not taking much weight through their feet. There's nowhere to hide on a tilt table. All his weight is concentrated through his feet. We're just exploring a bit of weight shift, pushing him around a little bit, and we're noticing that he's getting some muscle flickers around his ankles, some quads are turning on. And then so we sort of progressed this as he got a bit better to standing wedged in between 2 physiotherapy plinths and taking more weight and gradually reducing the weight from his arms. And then once he was more confident doing that, we always do lots of sit-to-stand practice. It sounds boring, but patients actually quite like it because they can see a change. So here he's using the stand to sit to get some automatic eccentric control through his quads. When he stands up, he throws himself forward, uses momentum, which triggers his sort of his extensors, essentially. It was here that his first block of treatment had to end. We'd run out of time. And actually, during physiotherapy, he had a couple of functional seizures. They were mostly moments of absences, and physiotherapists don't treat functional seizures. But we know about it, and we're able to recognize it because we see lots and lots of them if we work in an F&D service. So we were able to talk to him about it. We were able to talk about Does he recognize any warning signs? What are the things that might trigger it? And what can he go away and do while he's waiting for psychology? And so we introduced, maybe, why don't you just have a go at some of these grounding techniques? So he went away. He had very, very good psychology. He had some treatment for some residual PTSD symptoms. And when he came back to us 6 months later, he no longer had seizures, and he was in a really great place to continue his rehab. In fact, he'd been practicing his weight bearing, and he was able to stand with his hands off after 6 months. This is him trying to walk. So he was doing some of this at home, and he's got that monoplegic dragging gait, which we see in FND, and he just can't clear that right foot. So let's push it forward. And we do lots of sit to stand like I already showed you, but this is our next trick. We do lots of weight shift. So this is what's called in F&D, or what's called in motor relearning, is sequential motor learning. So we're building up the components of gait. In gait, you need to be able to single leg stance and single leg stance on the other side. And so that's what we're doing. We're practicing lots of weight shift to be able to initiate it or shape it into walking. But he still couldn't clear that foot. So he's still dragging it behind like I showed you. So sometimes we get out a FES device to get some electrical stimulation of his tiband. Really, it probably acts as a bit of distraction as well, helps clear his foot, and we use it as a rehabilitation aid, not a walking aid. So he's got it there on his right foot, and he's back to that weight shift. He's initiating stepping through weight shift. So he's not thinking about a step, it's a redirection of attention. And we progress it further to some facilitated walking. Oops. There shouldn't be sound, but there is. So really, that's my colleague Cameron. He's facilitating his gait with light touch. And really, he's redirecting his attention, and he's bringing it back to weight shift rather than thinking about stepping. And what's happening in his feet's happening a bit automatically because he's being pushed forward. And lots of treadmill training. And this is him at the end of treatment. So we sent him away, and then we followed him up at 3 months, 3 months later. So here are his outcome measures. His 10-meter walk speed, he couldn't walk when we saw him. When we left him, it was at 0.27 meters per second. When we followed him up at 3 months, it was even faster. Same with his Berg balance score, we saw a progression. This is the functional mobility scale, which measures what walking aid they need over 550 and 500 meters. Initially, he was wheelchair dependent for all of them. After treatment, he was able to walk short distances, but he used crutches for longer distances. When we saw him at follow-up, he could do a little bit of running, but mostly walking. So he was still progressing, but we saw this real change. After treatment, he continued to get better. Here is his CGI. This is the patient's perception of change. Immediately after treatment, he goes, "I'm much better." When we saw him at 6 months, his outcome measures were all better, but what do you think his CGI was? It wasn't quite as good, despite his numbers getting continually better. And we see this all the time in these patient-reported outcome measures. So it's all relative, isn't it? The goalposts move. So now I can walk, but I have an enormous amount of pain, and I'm really fatigued. And maybe there are some other health problems around there that sort of makes life very difficult. So this is a good score for him, and it's a meaningful score for him, even though it didn't make sense to me. We do a workbook, and we ask patients to write notes and reflect on every single session. And so Ed shared some of his reflections for me to share with you. This was a reflection early on. I'm going to have to kneel in to read it. When we went through the symptom model, the explanation of F&D, which was when everything made sense to me, it was like a light bulb being switched on. We spoke about the nervous system, and it's obvious to me now that my sympathetic division is working to the extreme all the time, and this explains my fatigue. So he's developing sort of, I guess, more of a biological/psychological understanding of his symptoms. Here's a reflection from later on in treatment. I then went back on the treadmill, and I was walking at speed for about 5 minutes. As the treadmill got faster, I instinctively felt like I needed to run, and so I did, and it felt fantastic. If you want to have a look at our treatment resources, you can download them, and if you'd like to, you can use them. So that leads me to thank the people who've done all this work with me, including the trial team and the people I work with at St. George's. Everyone is in the room today, Jan, Tiago, and Marianne. Maybe you'd like to know about a free network that I run with Glen Nielsen, who's an occupational therapist. This is for NHS AHPs who would like some support treating people with F&D. We get together, we do quarterly webinars, and we have different speakers. Some of you, a lot of you in the room have done talks for us, and it's just an opportunity to get some education about F&D. Anyone can sign up, and we'll send you an email once every other month with education opportunities that are free. The next one coming up is on seizures. And join the FNDS. It's really fantastic and exciting. They have a brilliant course coming up on epilepsy and functional seizures, which was put together by Mahinda Yogaraja and also the FNDS president, Barbara Dwetsky. Thank you very much for your attention.